Hi friends, welcome to my channel Optometry Online. The topic for today's video is about hypermetropia, clinical classifications and management of hypermetropia. By definition, hypermetropia or long-sightedness is a refractive error where the parallel rays of light from the infinity getting focused behind the eye with accommodation being at rest. The symptoms of hypermetropia are eye strain, blurred vision, headache, squinting of eyes and loss of accommodation. So this eye strain and headache occurs because they have to put a constant accommodative effort in order to make the vision clearer. So they end up in having eye strain, which they say it as tiredness of eyes, watering of eyes, or headache while reading, etc. So blurred vision, they usually have a difficulty in reading, but when the degree of refractive error is very high, they usually have difficulty in both distance and near. And when the refractive error is even more higher, they usually also complain about loss of accommodation. The signs of hypermetropia are the eyeball is usually smaller compared to a normal emmetropic or a myopic eye, and as the eye itself is crowded, they usually have a shallow anterior chamber. The cornea is flat and smaller, and in retinoscopy we usually see a width reflex, and in fundus examination the optic disc is usually smaller with ill-defined margins, which might simulate a papillitis. So clinically, hypermetropia is classified into simple, pathological, and functional. Simple is the most common variety, and it is acquired due to the normal biological development. Pathological one is acquired due to the various ocular condition. Functional is because of the nerve induced the paralysis of the nerve. So in axial hypermetropia, even a 1 mm shortening of the eyeball can cause a 3 degree of hypermetropia. Usually we are born hypermetropic, and as we grow, the eyeball grows and hypermetropia usually reduces. So the other causes are the curvature one, where the cornea is little flattened. Index hyperopia occurs in case of cortical cataract, where it is usually seen in older people. Positional hyperopia, where the crystalline lens inside the eye is getting got dislocated or subluxated behind the eye in the retina, so which can cause a hypermetropic shift. And aphakia is a condition where the lens is absent or it is surgically removed. So in case of aphakia, there will be a strong hypermetropic error. So the components are latent, manifest, facultative, absolute, and total. So these are some of the components. We'll see about this in the later slides. So latent hypermetropia is which is by the inherent tone of the ciliary muscle, which can be seen only with the cycloplegic refraction. Manifest hypermetropia, which cannot be corrected by the ciliary tone. So the patient will be using its own accommodative effort. The patient has to clear the hypermetropic error, so which is further classified into facultative and absolute. So facultative, which can be corrected by patient's accommodative effort, and absolute, which cannot be corrected by the patient's accommodative effort. So total is the sum total of both latent and manifest. So we have a small example of a hypermetropia, which has all the components of hypermetropic errors. So this is how a patient with uncorrected visual acuity of 3 diopters. So they usually have a blurred visual acuity chart. So so this person cannot see the chart. So when you're going to put a marginal hypermetropic correction, the letter starts to get clearer. So since this minimal amount of power is able to make the patient use his own accommodation. So this 1 diopter is the absolute hyperopia. So as we proceed for the further refraction acceptance, so we see that after putting 1 diopter, so this 2 diopters, 3 diopters, so the patient is still able to even after under correction, the patient is able to see the charts little clearer. So this is the facultative, where the patient can use his own accommodative effort to make the things clearer. So once you achieve the maximum power, the patient is able to see the last line very clearly. So after this is attained, we usually instill a cycloplegic drops to assess the accommodation and to assess the ciliary tone hypermetropia. So that gives the exact amount of hypermetropic correction. So in this patient, we usually we got the value of +4 diopters. So this component is in this patient, we had absolute of 1 diopter, facultative from 1 to 3, so just 2 diopters, latent after putting the drops, we got the value of +4. So 3 from the 4, subtraction value gives plus 1 diopters. So total value is 4 diopters. So this is how we classify the hypermetropic error into different subclassifications. So how do you manage? So hypermetropia is very risky because when the refractive error is very high, it can cause a risk of developing amblyopia. And in amblyopic cases, we are supposed to give a full correction. And some cases, the patient also have a convergent squint. Even in such cases, we are supposed to give a full correction. And there are some cases when there's exophoria is present. So we are supposed to undercorrect the hypermetropia because the overcorrection can cause more symptoms than doing better. And in asymptomatic cases, the patient doesn't have any symptoms at all. So better not to correct when the patient refractive error is less than 1 diopters. So management of hypermetropia is usually given by the convex lens, which makes the lens the rays of light to get focused on the retina. So it can be either achieved by glasses or contact lenses. So they are both usually the standard way of correcting. So if the patient is not cosmetically not good wearing a glasses or contact lenses, the patient can go in for a LASIK surgery to correct the hypermetropic correction. So these are all for the hypermetropia. I hope you liked the video. For more optometry related videos, kindly like, share and subscribe my channel. Thanks for watching.